everyone, this is Katie Ilten from Frederickson and Byron. Good morning to those on the West Coast, happy lunchtime to those here in the Central Time Zone, and good afternoon to those of you who are from the East Coast. Thanks so much for joining us today. Also presenting today are my colleagues Marguerite Ahmann and Briar Andresen.
Hello.
We are, as many of you I'm sure are, all in different locations, and so we continue the grand experiment of Zoom webinars from many different locations. So thanks for bearing with us as we go through here. Before we dive into the content of today's webinar, I want to cover a couple housekeeping items. We will plan to address questions live at the end of the program. To submit the questions, please send them through the Q&A box, which you should be able to access through the Q&A button on the bottom of your screen. We have enabled a new feature today called the upvoting feature, which means you can like questions that are submitted by your fellow listeners so that we can tell which questions are the most popular. So hopefully you upvote all the easy questions for us. If you have any non-question comments during the program, our staff is going to be monitoring the chat box as well. We are recording today's webinar, as we always do, and you will receive an email once the recording's been posted online. And you'll also, in that email, have a link to download the PowerPoint slides. I think there maybe was one minor edit that we made after you received them. So if you want the latest and greatest, just follow the link in that email. You'll also, if you joined us live today, you'll also get information on continuing education details via email once we've received all the various approvals. You can find this recording and webinar and all of our webinars on our website and our YouTube channel, where you can listen to them for free anytime or forward them to anyone who think might be interested. Please do complete our survey at the end. We really do value your feedback and try to pull topic ideas and ideas for improvements from that survey. And please, if you do want us to contact you directly, you need to put your contact information in that survey, because without doing that, it's totally anonymous, and we don't know who's asking the question unless you tell us. Next month in July, we're actually going to be taking a little bit of a break, kind of a summer break for our webinars, and hopefully you all will get some time away as well. We are going to resume in August, likely August 12th. That's the second Wednesday when we typically do these webinars. And we'll do our popular kind of FAQ format in August, but we'll be focusing more specifically for most of those FAQs on any COVID-19 developments, regulatory developments with respect to the pandemic, as it will have been a while since we've done one of those presentations. So with that, let's turn right to the content. So today we've structured the webinar to be as close as we can do a direct training session. So the idea here is that you should be able to provide this presentation to your workforce in its recorded form for basic HIPAA training. And maybe some of you are out there listening for basic HIPAA training right now. Another way you could use this webinar is to take the slides and our recording and use it to sort of train the trainer, or equip yourself or one of your staff members to provide your own sort of training to your workforce using our materials. So because we are doing a basic training kind of concept, we aren't going to be getting into super deep legal analyses of the HIPAA regulations. It's really designed to cover the basics of the three components of the rules of HIPAA, and discuss some common HIPAA issues and go through some hypotheticals to give your workforce some practical information for compliance training. At the end, we're going to take some Q&A, and actually the Q&A portion will probably not be on our recording, because we want to give you as clean of a recording as possible, as clean of a presentation as possible, so that you can present it to your workforce later. All right, so with that, I'll just mention that this slide has our acronyms we're going to be using throughout the webinar. If you ever have a question about what an acronym is, just reference back to this slide. So what is HIPAA? Starting from scratch, HIPAA is a federal law, the Health Insurance Portability and Accountability Act. So that's HIPAA with 2 A's, not 2 P's. It's a federal law that is really the big goal is to protect individuals' protected health information. HIPAA really regulates entities and not people. It regulates covered entities, or CEs as we refer to them. Covered entities are kind of 3 types of entities. Probably most of you are in the first type, which is a healthcare provider. Also a health plan and a healthcare clearinghouse, those are also covered entities. And if you're a healthcare provider, health plan, or healthcare clearinghouse that engages in electronic claims billing, which most of them do, then you're a covered entity and you're regulated by HIPAA. HIPAA also regulates business associates, which are third parties that touch PHI in some form or manner when they are doing functions on behalf of a covered entity. So for example, a coding and billing company is a business associate of a healthcare provider that's a covered entity under HIPAA. There are 3 kind of components or buckets under HIPAA. There's the privacy rule, the security rule, and breach notification rules. The privacy rule, the goal is really to protect PHI and to give individuals certain rights with respect to their PHI. For example, the right to access their PHI or get copies of it. The security rule governs how a covered entity or a business associate is supposed to safeguard electronic PHI. So this is really the portion of HIPAA that deals with things like passwords and firewalls and encryption. And then breach notification is the part of HIPAA that obligates covered entities and business associates to notify individuals, the government, and sometimes even the media, if it's a big breach, about breaches of health information. Importantly, HIPAA sets a floor for the protection of health information. So we'll talk about that in a minute, but basically it's the minimum amount of protection in the US that is provided for health information, and states may be more protective. So before we dive into kind of the 3 different types of HIPAA, or the 3 different rules under HIPAA, I'm going to talk a little bit about enforcement to sort of give you some context as to how HIPAA is enforced. So the Office for Civil Rights is a federal agency that enforces HIPAA. And again, they're mostly enforcing this law against covered entities and business associates. That means the government is calling out covered entities and business associates when they have not followed the rules. There is not a private right of action under HIPAA. So it's not possible for a person who's been aggrieved of and is upset about their privacy rights being violated, it's not possible for them to sue someone under HIPAA. This is an enforcement by the government against entities. State attorneys general can, under HIPAA, bring a civil action at the state level on behalf of state residents who have been affected by HIPAA violations. So there is some state component of enforcement here. But mostly you see OCR, the federal agency, enforcing. And the way that OCR gets the idea to enforce HIPAA and to look into violations is really complaint driven. So that means most of the OCR investigations that occur come because of someone complaining about the fact that a covered entity or a business associate has done something wrong with their PHI. So that's why, obviously it's important to protect patients' PHI because of the confidential nature of it. And we want to honor patients' rights to confidentiality. But secondly, it's important to protect individuals' PHI and to pay attention to patient complaints, because that is the main way that that a covered entity or business associate can get into trouble with OCR. So what kind of trouble are we talking about? Well, as I said, covered entities, business associates are typically the people who are getting into trouble. Individuals HIPAA can be enforced against individuals, but you're talking about really egregious criminal circumstances if that happens, and it has happened. So individuals who are really bad actors with respect to HIPAA can get into hot water. The types of enforcement that can take place, well, usually if it's bad enough, a covered entity or business associate has to enter into some sort of agreement with the government to make itself better and to improve its activities and to behave appropriately. The covered entities can also face civil money penalties or civil fines. And then again, for really bad actors, there can be criminal fines or imprisonment. So it's not something that you want to take lightly. And on this slide, I just have the varying levels of civil money penalties. So as you can see, as conduct gets worse or the worse the violation, the higher stakes in terms of the types and amount of civil money penalties that could be assessed by OCR. Now, before I turn it over to Margie to talk about the privacy rule, I'll just go back to this idea about the HIPAA being a floor of privacy protection. As I mentioned, HIPAA sets the minimum amount of protection for protected health information across the United States. Many states have enacted more protective confidentiality statutes or health information protection statutes. Certainly California, New York, here in Minnesota, even North Dakota has some provisions that are more protective of health information than HIPAA, which means that while HIPAA might allow a covered entity to make a disclosure, it may be that the state law has a stricter requirement and you would have to get consent of a patient to make a disclosure, where HIPAA wouldn't require you to. Obviously, we're not going to be talking about all the state's laws. That webinar would go on for days and days, but it's important as you're training your staff and as you are wherever you are to understand that there may be state laws that are more protective of health information. And the rule is that when the federal HIPAA law lets you do something, but the state law says you can't, you have to follow the state law. So it's important to incorporate the state law considerations into your policies and to make sure your staff is trained on state law.
And Katie, this is Briar Andresen. If I could just jump in real quickly, we did get a question that I don't want to skip past about how the penalties are applied. The questioner says, I always submit my breaches to DHHS every year as required, but haven't ever been required to pay anything. And to that, I would say congratulations, that is excellent. And that is also fairly common. Most of the reports of breaches do not result in penalties being applied. Most investigations by OCR result in them closing the investigation without doing any sort of penalty assessment. Usually it is just you have to change things, you have to deal with the investigation, but it doesn't usually result in a monetary penalty.
Thanks, Briar. That's a great point to understand about enforcement. And I'm also glad that that they haven't had to pay fines by submitting breaches. I'm going to turn over to Marguerite to talk about privacy rule basics.
All right. Thank you, Katie. We're going to dive into some of the basic protections and rights under the privacy rule. First, we're going to start with how the covered entity is permitted to use and disclose protected health information, or PHI. HIPAA specifically permits a covered entity to use and disclose PHI for the various reasons listed on the slide. First, and somewhat obvious, is the ability of the covered entity to disclose PHI to the individual or to the individual's personal representative. A second key category of permissible disclosures are those for treatment, payment, and a fairly broad category called healthcare operations. Healthcare operations disclosures are, they're generally disclosures that are needed to be made by the covered entity in order to operate the business. So these are disclosures for accounting or legal purposes, quality assurance activities, if you're involving a vendor to do some sort of software maintenance, those are all under this category of healthcare operations. HIPAA also permits disclosures as required by law. So that could be situations where there's a court order for disclosure of information, or where the state requires disclosure, let's say for vital statistics information. Covered entities can also disclose to business associates, but in those cases there needs to be a business associate agreement, which we'll talk about in additional detail later in the presentation. You can also, as a covered entity, disclose as otherwise authorized by the patient. So if someone wouldn't have a right to the information, but the patient gives you specific authorization to do so, a covered entity is permitted to disclose in those cases. And then there are a slew of other permitted disclosures as well, and those are listed on the screen. We'll talk in a little bit more detail about disclosures to family and friends on the next slide, but some other additional permitted disclosures are to public health authorities, to report child abuse and neglect, to law enforcement, but only under certain circumstances, research purposes, but in those cases you typically either need an authorization or to have an IRB give specific waiver of those authorization requirements. So there are a number of nuances to the permitted disclosures listed on the slide, and there are some big asterisks there because, as Katie mentioned, state law also has to be consulted, and these disclosures are ones that state law is particularly likely to impact in terms of the scope or the process for making these disclosures. All right, so disclosures to family and friends. It's a fairly familiar scene where a patient brings along a family member or friend to their appointment, and HIPAA does generally permit a provider or covered entity to discuss information that would include PHI with that individual that the patient brought along. So as a general rule, disclosures to family or friends are permitted when the patient is present and has capacity to consent, and the patient has either agreed during that visit, has previously made their agreement known, or has been given an opportunity to object and has not objected, or if it can be reasonably inferred from the circumstances that the person does not object to the disclosure. You know, in a circumstance where the patient has brought somebody along into the exam room with them and they are starting to openly discuss their medical history and treatment, it can be inferred from that circumstance that they are okay with the disclosure to the person that they invited along. In emergency situations where the individual doesn't have the ability to consent, the rules are a bit different. In those cases, the professional needs to determine whether it's in the patient's best interests to make any disclosures to the people involved in their care, and then those disclosures have to be restricted to just what is directly relevant to the care, as well as that person's involvement in the care. So as a general rule, you can use your professional judgment to make reasonable inferences about who's permitted to pick up prescriptions, supplies, or making other kind of similar incidental disclosures of PHI. But as a general rule, if there is any sort of question or doubt whether a person has been has consented to those disclosures, we always suggest that you err on the side of caution and check with the patient first. That is a very common complaint where a patient gets very disgruntled that a provider continued to disclose information to a family member or friend beyond what the patient was initially comfortable with. Moving on to incidental disclosures. So HIPAA permits incidental disclosures and contemplates that even the most reasonable and prudent of covered entities are going to make certain disclosures that are sort of incidental to the practice of providing care and treatment to patients. So an incidental disclosure is one that's allowed only if it's a byproduct of another permissible or required use or disclosure of PHI, and only if the covered entity has implemented reasonable safeguards against impermissible disclosures. So these reasonable safeguards are going to vary from entity to entity and will also depend on the type of information that you're disclosing. So discussions around particularly sensitive patient information should always come along with more protective safeguards. But some of the safeguards that you can consider are things like turning off computer monitors when you walk away, using soft voices in common areas, leaving any papers that have PHI covered or not faced in a direction where another patient would maybe be able to see and view the information. So the incidental disclosures also go hand in hand with covered entities' minimum necessary policies and procedures, which we'll talk about in more detail in a second here. So some examples of incidental disclosures include when healthcare staff like nurses are going to discuss or coordinate care at a nursing station. It's possible that other patients within the facility would overhear information that would be PHI, as long as the staff are making reasonable efforts to safeguard that information by keeping voices quiet, only disclosing and discussing the minimum amount necessary to coordinate care. That is a permissible incidental disclosure. Other examples include when health professionals have to discuss care over the phone with the patient and wouldn't be able to tell with certainty who else might be able to be privy to those conversations, or when a physician is discussing a patient's condition or treatment and the facility has them within just a semi-private room. Again, using quiet voices and limiting the nature of the information disclosed, all will help that fall into the category of a permissible incidental disclosure. But it's really all about reasonableness. So if there was another very reasonable manner to have disclosed the PHI that wouldn't have resulted in an incidental disclosure, covered entities should be looking to implement safeguards to make sure they're using those reasonable alternatives. So on the minimum necessary, so a covered entity is required to only use and disclose the minimum amount of PHI necessary to accomplish the purpose of the request, use, or disclosure. So this is a very simple concept, but it is often overlooked. It's also often overlooked that this applies to both internal and external uses or disclosures of information. So as a workforce member, it's very important that any sort of uses or disclosures of PHI are consistent with your job responsibilities. So a front office manager or a scheduler is not going to need to access a full patient record in order to do their perform their duties. So you should be reviewing and using PHI only as necessary and within your job responsibilities. This also applies externally, so with business associates, if you have a third party, a vendor coming on site, they should only be allowed to use and disclose PHI as necessary to perform that business associate service. There are a set of circumstances where the minimum necessary standard does not apply. And this really goes to various different policy rationales why we wouldn't want to limit somebody's exposure to information. And the first one on there is disclosures to or requests by a healthcare provider for treatment purposes. And we don't want healthcare providers to have to guess or limit the amount of information that they see about a patient when providing treatment purposes. Another one is when you make uses or disclosures to a patient of their own PHI. We'll talk more about the right of access, but they have the ability to see and be exposed to all medical information about them. When you make a disclosure pursuant to a valid authorization, you can rely on the scope of the authorization. You don't need to do any sort of further analysis about what is the minimum necessary for that third party. and then disclosures to public officials when it's required by law and the public official has indicated that their request is the minimum for that particular purpose. So business associates, we talked a little bit about this already, but when a covered entity is working with an outside vendor or entity, and that relationship requires the outside entity to create, receive, maintain, or transmit PHI while performing a service on behalf of the covered entity, then the covered entity needs to have a formal contract in place. It's called a business associate agreement, and it governs the business associate's use of the protected health information, as well as governs what kind of safeguards that they need to have in place while handling PHI. So common examples of business associates include document storage companies, IT vendors, shredding companies, outside counsel and outside coders. And the key takeaway here is if you're sending PHI outside of your facility or your clinic, or if somebody is coming on site and will have access to PHI, you want to make sure that there is a business associate agreement in place, or it's some other way to control that information. All right, on de-identification. So the wonderful thing about de-identification is that once information has been de-identified, it is no longer considered PHI, and it is no longer subject to the restrictions imposed by HIPAA. The complicated or difficult thing about de-identifying is it's not as simple as just striking a patient's name or other clear identifiers from the record. In order for information to be de-identified, it cannot identify the individual, but it also cannot have any sort of reasonable basis to identify the individual by combining other identifiers or other factors. So an age, date of service, address, or other indicators like that could be combined together to identify an individual. So HIPAA provides two different ways to accomplish de-identification. The first is by engaging the services of a qualified statistical expert. And the second is by falling under a safe harbor, which I will go on to the next slide and show you that in order to fall under the safe harbor, you need to be removing all of the identifiers listed on this slide for it to be considered de-identified. So that's a pretty big task to remove all of these factors, but once they are, then you can consider that record or that piece of information de-identified. All right, so moving on to patient rights, which is the second big part of the privacy rule. And the privacy rule gives a number of explicit rights, which include an individual's right to access their health information, the right to request restrictions on health information, the right to amend the health information, to request an accounting of disclosures, and the right to request confidential communications. So let's talk a little bit about the right of access. The privacy rule generally requires covered entities to provide individuals with access to their protected health information upon request. So that's the right to either inspect or obtain a copy of PHI, and also includes the right to direct the covered entity to transmit a copy of their electronic health information to another person of their choice. A covered entity has 30 days to provide access, and then there's a one-time 30-day extension that goes along with each request. If a person requests an electronic copy of their PHI, which is maintained in a designated record set, a covered entity is required to provide access in the form or format requested by that person if it's readily producible in that format. If it is not readily producible in the requested format, then the individual and covered entity should work together to find a different reasonable means of providing the information. a patient also has the right to request PHI in various formats, including the right to request it by unencrypted email. However, a covered entity shouldn't send PHI via unencrypted email unless they've taken the extra step of advising the individual of the risks associated with transmitting PHI via unencrypted email, and the patient specifically consents to receiving it via unencrypted email. Another common question that comes up is whether individuals have the right to kind of show up at your office with their own portable media and have you download their information onto that. And there, you are not required to do so. That could introduce various different security risks to your system by, let's say, taking their jump drive and plugging it into your systems. But you do need to have some sort of reasonable electronic format to provide the information to them. So you should consider, flash drives or USBs, having a patient portal, or having an encrypted email system to provide them with information. So the right of access, like I mentioned, also includes the right to have the individual direct an electronic copy of their PHI to a third party. For those, the request does have to be in writing, signed by the individual, and clearly designating where they want the information to be sent. I will note that this is different from an authorization. An authorization has to include various different components as required by the HIPAA regulations. Under the right of access, a patient can just make a more simplified request, but again, in writing if it's going to be directed to a third party. When a patient requests records, HIPAA provides some guardrails around what a covered entity can charge for providing the records. So the standard under HIPAA is a reasonable cost-based fee, and that permits the covered entity to only charge for labor costs involved in copying the PHI, supplies or postage. You can charge for labor related to preparing a summary or explanation, but only if you have discussed that with the patient in advance and they have agreed. There are, those are the parameters set. You're specifically not allowed to charge a retrieval fee. OCR has put out a ton of guidance on permissible fee options, but they've made it clear that this is not supposed to be a revenue stream, charging patients for their own records. And I will also say that you should make sure that you are considering state laws here. Many state laws provide a schedule of fees, but again, this is an area where HIPAA's reasonable cost-based fee may actually set a lower amount than the state's fee schedule. So you want to make sure that as a covered entity, you've looked at both. Most workforce members should be able to look to the privacy officer or their records department to have determined a schedule of fees or a methodology for determining fees. All right, a covered entity is also required to permit an individual to request that the covered entity restrict uses or disclosures under various different circumstances. While they have the right to request, a covered entity generally does not have to agree to restrict disclosures, except when the patient has made a request related to restricting disclosures to a health plan and the patient has paid in full. So if a patient shows up, wants to have treatment, explicitly doesn't want any information sent on to their health plan, you must agree to that, provided that the patient is willing to pay in full. And to further that, you are permitted to ask the patient to pay upfront, and in the event the patient does not pay upfront and does not then end up paying, the covered entity is permitted to bill insurance in that circumstance. There are various other patient rights that I'm only going to touch on, but the patient has the right to request confidential communications, and on this one, a covered entity is required to agree to any sort of reasonable requests made. So if a patient doesn't want you to leave messages on their home answering machine, or if they want you to use a particular number or particular address, those are all reasonable restrictions to maintain the confidentiality of their of communications with them, and those are things that you would need to agree to. A covered entity also must give patients the right to request an amendment to the PHI, and you have to consider them and reply to them, although you do not have to agree to amend the record. There's a very specific process that's outlined within the HIPAA regulations that provides them with an opportunity to object, and more of a procedural guideline around that. Patients also have the right to request an accounting of disclosures. So if they come to you and they want to know everyone who has seen their medical information or been given a copy of their medical information, HIPAA requires covered entities to keep a list, an accounting of those disclosures. But there are various different disclosures that do not need to be accounted for or described, and those include the ones on the screen, like disclosures for treatment, payment, and healthcare operations, disclosures you made to them or to other individuals that they authorized, incidental disclosures, and a few others. So there are nuanced requirements around using PHI for marketing and fundraising. And regarding the sale of PHI, that's generally prohibited under HIPAA. Most workforce members shouldn't be engaging in activities that would fall into the category of marketing, fundraising, or selling of PHI. But we briefly want to touch on them in order to flag that these are kind of a red flag category. And so you should be working with your privacy officer or other administrator if activities seem to be falling into these categories. Generally, marketing will require authorization from the individual, and for fundraising purposes, disclosures or use of PHI is okay, but provided it's a very limited set of PHI and only for internal fundraising purposes, not for other external entities. All right, so we've talked a lot about other disclosures that can be made based on a HIPAA authorization. A HIPAA authorization is a specific form that you provide to patients, and it has to include certain language in order to be a valid authorization. It needs to talk about the purpose of the use and disclosure. It needs to outline and give patients a right to revoke the authorization, and needs to describe when a covered entity can condition treatment on filling out and making an authorization. I will note that when a patient comes to a clinic or facility, they are often provided with a notice of privacy practices that describes the various different ways that a covered entity will use and disclose their health information. That is not a HIPAA authorization, and having a notice of privacy practices alone is not a substitution for getting a HIPAA authorization to make disclosures that aren't specifically permitted by HIPAA. And on that note, I will turn it over to Briar to talk through the security rule.
Excellent. Thank you very much, Marguerite. And I am going to try and make sure that I can advance the slide here because we have one of my very few cartoons coming up. In any case, Katie, if you can advance the slide, that would be helpful. There we go. We have our three little bears here who are looking at their computers and wondering who has been trawling through my personal information. And this is kind of our intro to the security rule, which is put in place to protect the security of the electronic information that covered entities have. And as all of us know, that information is increasing in volume every single day. Entities have tons and tons of protected health information, and so the security rule tries to set a framework for how to protect that. I'm not going to go into lots and lots of detail about the security rule here because your entity's privacy officer and security officer, and especially IT team, whether that's internal or an IT vendor, are generally going to be tasked with most of the security rule obligations. But it's important for physicians, owners, all the staff of every covered entity to have real buy-in on the security rule, because not devoting the resources to security obligations can really result in some major problems for the entire organization. So the basics of what the security rule does, it requires covered entities to protect confidentiality, integrity, and availability of electronic PHI. It has separate categories of how you do this, both administrative and physical and technical safeguards. And there's a lot of guidance from OCR, the Office for Civil Rights, on how to comply and what to do, but it's still really difficult, and entities need to be really vigilant about how they are trying to do this. The key thing with the security rule is each entity has to perform a security risk assessment and then implement protections based on that risk assessment. So essentially this means that if there's PHI at risk anywhere in, electronic PHI at risk anywhere in the organization, the covered entity has to find that risk and has to determine the best way to mitigate the risk. So information on a computer is a potential risk, but the risk can be mitigated with passwords and encryption, for example. You also have to protect against reasonably anticipated threats. So if it's reasonable to assume that a hacker is going to try and get into the server needs to be protected in various ways, and how to do that is kind of up to the IT staff. The security rule is intended to be flexible so that covered entities and their business associates might have different paths to compliance, depending on size, the amount of PHI they have, and their ability to implement various measures. Obviously, a billion-dollar corporation is going to have a lot more resources to draw from to protect that information than a two-physician clinic, but the obligation to protect information is still there, and the risk assessment for any entity has to figure out where there are risks and how to deal with them. Some of the examples of threats we see with EPHI: theft of laptops or other devices, losing a laptop, so you don't know that it's stolen, but it's gone and you're not sure who might have it. Malware and hacking and ransomware are huge issues and certainly not going away anytime soon. Snooping employees, that is a continuing threat, and I think Marguerite sort of mentioned that in discussions about how if you don't need PHI to do your job, then do not use it, do not look for it, do not access it. And while that's a general HIPAA concern, it is also sort of a specific security rule issue when an employee goes searching through the EHR, for example. If OCR comes looking, they will say, oh, covered entity, you did not do enough to prevent that from happening from a security rule perspective. So it's a general HIPAA violation, and we're also finding that you violated the security rule by not dealing with that. I think the snooping employee issue is one of the most difficult for covered entities to deal with because even though HIPAA has been around for a long time and we've all been dealing with this forever, it seems like some people have not yet gotten the message to not look up their ex-girlfriend's stuff. So more examples: emailing PHI to the wrong recipient, also a potential security rule violation. Inadvertent disclosures where you've got PCs in the exam room and the previous patient's information is still up on the computer screen when a new patient comes in. It would be a question about whether that was a violation or not, whether it would be a breach or not, but we'll discuss that in a little bit. And then natural disasters are on here. That is a threat not so much to the security of PHI necessarily, but to the availability of PHI. So those are all things that have to be addressed in the risk analysis. Again, the covered entity determines who's responsible for developing these things and implementing security rule policies. So organizations should really focus on who's responsible for assessing whether laptops are encrypted. If you've got something on your mitigation list, then the employees have to know who's responsible for that, how are we getting it done. And then identifying which employees need access to PHI, and this is something that was discussed previously as well with the minimum necessary. What levels of employees need access to which type of ePHI? And then provide security awareness and training. And that is this in part, but also kind of regular reminders about passwords and other security measures that are in place. There was a question that came up on the Q&A about encryption. Encryption is not a requirement for every covered entity. It is something that the organization has to consider, and reasonable security measures are required. So if you haven't encrypted your stuff, OCR might decide, oh, you know what, encryption was reasonable for your organization and you should have done it. So the safest option is if you can encrypt something, you should encrypt that. And this next slide gets to that a little bit. The type of stuff that you can encrypt, laptops, phones, flash drives, iPads, desktops, do all of that if you can. Passwords, also obviously super important. Periodic security rule audits to make sure that all the stuff that you've said you were going to encrypt is actually encrypted. And then if something isn't encrypted, use extreme caution. So if you are, if you're giving an unencrypted thumb drive to a patient who has requested that they get their information that way, be really cautious not to lose that somewhere or mail it out in a way that it could be accessed by somebody else. Just use extreme caution if it's not encrypted, because if it is encrypted, you are in much, much, much better shape if it gets lost or stolen. One quick example of a recent settlement, a relatively recent settlement that OCR had. This was $150,000, which is a pretty low amount for what OCR usually comes up with, but it was, for a relatively small community mental health services covered entity. They had to pay $150,000 and do a corrective action plan after they had a malware incident with unsecured PHI. And we'll talk a little bit again about what unsecured means in just a couple slides. The investigation that OCR did said that they had adopted only sample security rule policies way back in 2005 when the security rule was relatively fresh, but they didn't follow even those sample policies. And the security incident was a result of the entity not identifying and addressing basic risks like updating their IT resources with available patches and running outdated or unsupported software. And that patching issue is huge. The patches come out so regularly to fix these issues that hackers have identified. So you've got to make sure that whoever is in charge of your IT is really staying on top of the patches and doing those as soon as possible. A word about mobile devices and HIPAA. We all have our mobile devices all the time, and they can be very useful. But if you are having any PHI on this, if you've got access to company email that could have patient information, if you use it to communicate with patients, it's very important for the covered entity to make sure that it's protected. So password protection is a minimum, an auto lock or log off. Again, make sure that IT is regularly installing security patches and updates. Encrypt, if at all possible, include antivirus software on there. The ability to do a remote wipe is really important in case the device gets lost or stolen. Having a privacy screen is something to consider. And this bottom bullet point here, don't use the camera. If you are using your phone at work to take a picture of anything that you see at work, that is really, really risky. Don't take pictures of patients. don't take pictures really of anything having to do with your work if that can be avoided. Unless, of course, you are using it for a work purpose and work has determined that that is the appropriate thing to do. For example, if you need to take a picture of an injury and immediately upload it to the electronic health record, that sometimes is appropriate, but there should be a policy describing how that works and how to delete the image permanently after that. More on mobile devices, use secure Wi-Fi connections or use a secure VPN. This third bullet point is something that organizations sometimes consider, which was prohibiting downloading of third-party apps. Some of these apps get access to information that should not be shared, and so that should be something to review with IT. And then delete all PHI from that mobile device before you discard or reuse it. This next slide here, I thought it was funny because I spend a fair amount of time on Twitter. If you don't spend any time on Twitter, you perhaps have not seen this, and it's just sort of a ridiculous looking slide. But in any case, we are going to talk about what is and is not a breach. So the official regulatory definition, that breach of PHI is an impermissible use or disclosure of unsecured PHI. If there is that impermissible use or disclosure, it's presumed to be a breach unless the covered entity or the business associate can demonstrate that there is a low probability that the PHI has been compromised. So first thing, what is unsecured PHI? That is PHI that has not been rendered unusable, unreadable, or encrypted. So if you have something that is not encrypted, that is going to be considered unsecured PHI. If you have it encrypted, if you have shredded the paper that it is on, or if you've blacked it out so it's impossible to read, that is considered secured PHI, and you don't need to worry about that as much. But if it's unsecured, then that is going to be a potential breach. The regulations do have some specific language about what is not a breach. It is not officially a breach if there's an unintentional acquisition of PHI by an employee, if it's made in good faith and in the scope of authority, and it doesn't further result in further use or disclosure in violation of the rule. So if you are talking to your colleague about Briar Andresen's medical record, you're talking about it to somebody, and then you think, oh, you know what, you didn't see that patient, this other nurse saw this patient. If you have made that disclosure in good faith, it's what you would normally do, and that person that you told it to is not going to tell anybody else about it, that's fine and not a breach. It is also not a breach if a disclosure is made to an unauthorized individual who couldn't reasonably retain the information. And that is, you know, if you are handing a discharge summary to a patient, you realize as you're handing it to them, that is the wrong discharge summary. The person's had it for 5 seconds and they haven't looked at it. You take it back. That is not considered a breach because that person couldn't have reasonably retained the information. But those are pretty limited, obviously. And so these next factors are how you determine whether PHI has been compromised. You have to do this 4-factor test. First, look at the nature and extent of the PHI involved, including what kind of identifiers and the likelihood of re-identification. So if you've, as Marguerite pointed out, a medical record number is an element of PHI. If you give somebody a medical record number to someone who shouldn't have it, but the person who receives that, just the MRN, has no ability to figure out who the subject is of the medical record, that may argue in favor of that's not a breach. If all they have is an MRN, who cares? The second factor, the unauthorized person to whom the disclosure was made. So disclosing something to an ex-spouse is a lot more likely to be a breach than accidentally disclosing a medical record to a physician who's already under an obligation of confidentiality. Even if it's the wrong physician, if they get something, they receive an errant fax and say, oh, this is not one of our patients, we're putting it in the shredder, I would consider that likely not a breach. Next is whether the PHI was actually acquired or viewed. If PHI gets mailed to a group of people, including somebody who is accidentally on a distribution list, but the email could be pulled back before that inadvertent recipient opens the email, that would likely not be considered a breach. There are, various shades of gray that go around that, but in general, that's what they're looking for for that risk factor. Next is the extent to which the risk to PHI has been mitigated. So for example, if an email recipient does open that email, but confirmed that he's not going to do anything with the information at the risk of disciplinary action, the risk could be mitigated and there could maybe not be a breach, but that's something that the privacy officer is going to have to review and discuss. And then other factors can be considered where necessary. Again, this is in the regulations, but what that means is not totally clear. So you should be cautious about using the other factors to determine that there has not been a breach. If there is a breach, there is a reporting obligation. In fact, there are 3 reporting obligations. You have to tell the individual to whom the PHI belongs that it happened. You have to tell the government either immediately if the breach involves more than 500 people, or annually in the covered entity's breach notification log. And that first question that we answered earlier about making that annual report, that's exactly what that is about. You have an obligation to notify of all the breaches that you've had throughout the year. There's also a media notification obligation, again, if the breach involves more than 500 people. And I note at the bottom here, you may name individuals or a business associate in that notification. So if I have caused the breach to happen, the covered entity might say, Briar Andresen did this bad thing. Most of the time that does not happen. Most of the time the covered entities will just say this occurred, but it's much more likely for an employee to get named when it's kind of a rogue employee situation, again, a snooping employee, somebody that's taken purposeful action to compromise the security of someone's PHI. It's much less likely for people to be named when there's an accidental disclosure that results in that breach. If anyone listening at any point thinks that you might have identified or participated in a breach or potential breach, do contact your privacy officer immediately, because generally things get worse the longer they are left to drag out. Consequences of a breach, potential bad press, because sometimes the press has to be notified by regulation, but sometimes they just find out about it as well, even if it's less than 500 people. And then there are tons of financial costs that go along with it, including attorney fees, sometimes computer analysis, extra staff time, employee discipline and termination costs, and then if things have really gone wrong, potential penalties for the breaches that get reported to the government. And I think that is all I've got, and I will turn it back to Katie to talk a little bit about employee sanctions.
Thanks, Briar. All right, so before we move to some hypotheticals and then to our Q&A, just a note that HIPAA expressly addresses the issue of how to deal with employees who aren't following HIPAA policies and the HIPAA rules. It says that a covered entity is required by law to discipline and sanction employees who violate the HIPAA privacy security rule. So basically, this is HIPAA taking very seriously the fact that covered entities are supposed to require their employees to comply. Any violation of HIPAA is supposed to be handled in the same way, under the same type of discipline policy or practice that is used for other types of employment violations. So you're supposed to treat a HIPAA violation as you would another type of violation, and as most employers say that sanctions for misconduct or not complying with policies could include certainly warnings, reprimands, and could be up to and including termination of employment. And so HIPAA says very clearly that covered entities and business associates are supposed to discipline employees in the same sort of way and through the same processes for HIPAA violations that they would be held accountable to other types of employment standards. So although employees aren't directly liable under HIPAA, they are held to their employer's policies and procedures and should be trained on those accordingly. So we're going to run through a few hypotheticals now, and then we'll wrap up the presentation. So this first hypothetical says the patient's, let's pretend we're in an office setting, a medical office setting, and the patient's chart for the exam rooms are on the outside of the exam rooms in a folder, and their name is clearly displayed so that people who are walking by the exam room can, if they look, see the name of the patient who's in the room. Is this a HIPAA violation? And if it is it a breach? So in this case, you want to think about whether there is a better way to identify which patients are in the room for the people who need to go into the rooms, and whether that's a practical approach. Because as Marguerite mentioned or explained, the minimum necessary applies. And so the covered entity is to use the minimum necessary amount of information to accomplish the task. So the minimum amount of information necessary to room the patient. It may be that there's not a very good practical other way to identify which patients are in the rooms, but that's the sort of calculus you want to go through. I would say that it's very possible that patients' names on charts that are then on the backs of doors, it would be considered an incidental disclosure, right? So for example, another obvious incidental disclosure is that when you're sitting in a waiting room, you may hear a nurse call another patient to go back to their exam. HIPAA doesn't require you to never use or disclose information. It requires you to be practical and think about how to minimize the amount of information used. And so I think that the facts really drive this analysis. And so if the patient's chart if the name is in very small writing, if it's not easily seen by someone who's just walking by, it's probably not a violation and then wouldn't be a breach. But those are the sorts of questions you want to ask yourself when you're thinking about information that's out there, available to be seen, but is being used in the course of running your business. So the next hypothetical involves a patient who brings their spouse to every appointment. The spouse sits in the exam room every time during the exam, is involved in the conversations about the patient's treatment. And so in this example, let's say the patient had a biopsy done and that test results were going to be available after the end of the appointment. And so in this case, the spouse calls the clinic for the results of the patient's biopsy, and the clinic is faced with whether or not to disclose the results of the biopsy to the spouse. So as Marguerite discussed earlier, HIPAA does allow for disclosures to family and friends and people who are involved in the patient's care. But that's really talking about the situations where it's very clear that the patient was okay with and permitting the individuals to be involved in receiving information. So it's implied that when the patient brings someone to their appointment, the practitioner can reasonably assume that the patient is okay with that person being in the room and hearing the information. But when there's information that extends beyond that instance where the patient has very sort of implied consent, you need to be more careful. And so while it may be reasonable, or maybe you have an argument that it's reasonable to imply consent in this situation, I think that people could differ on that, and an investigator might say, look, you didn't really have the patient's consent beyond the end of that appointment. And so the best course of action is to always get in writing, at the very least get verbally, but to get in writing authorization from the patient to disclose test results and things that happen outside of the appointment. All right, hypothetical number 3. A hospital employee sees his neighbor at the hospital one morning and posts later on that day in the neighbor's Facebook page, "It was great to see you today." Is this a HIPAA violation, and is it a breach? Well, as it's written, all you have right now on the Facebook page is one person on Facebook saying to their friend, "It was great to see you today." So that's probably not disclosing any PHI because the person didn't say where they saw them or in what context. But if you change the facts a little bit, and the person who posted, the employee says, "It was great to see you at the hospital," that becomes a little bit less clear as to whether the poster has disclosed PHI. It gets a little bit grayer and I think a little riskier. If the employee says, "It was great to see you on the ICU floor today," and it's very clear from the Facebook page that the poster works at the hospital, I think you're definitely in the land probably of posting PHI, which in this case would be the fact that someone was at the hospital. Now, it doesn't say if they were a patient, so maybe you could argue the other way. But the more information you provide, the more likely you run into possibly disclosing PHI. Certainly the fact that someone is a patient somewhere is in fact PHI. So if the poster said, "It was great to see you, I'm glad you're recovering, it's great to see you on the ICU today," that's probably in the land of being a disclosure of PHI. And then the question is it a breach? And unfortunately with social media, once information is out there, it's really hard to mitigate the disclosure. And so unfortunately, when we're talking with clients and it involves PHI disclosures in social media, we're usually, if there's enough information to be PHI, then we're usually in the land of having to talk about there being a breach. So the point is, stay away from social media if you are a healthcare workforce, at least in terms of talking about who your patients and who you see on social media, who are your patients. All right, another hypothetical. A clinic sends an itemized bill to the wrong mailing address. The bill includes the name, the patient's name, the CPT codes for the services received, and then any patient due amounts. Is this a HIPAA violation? Is it a breach? Well, the fact that the bill had PHI on it, certainly anything about payment, CPT code, services rendered, and name is all going to be PHI. And so then you're going to, it's probably an impermissible disclosure. And then the question is whether it gets to be a breach such that you have to notify the person who's affected. Well, there may be some ways to say that there's a low probability that the information was compromised and that you've mitigated, or there are mitigating circumstances such that there wouldn't be a breach. If the envelope is returned and it's not opened, it's not a breach, we would say. If it's returned and opened, but someone promised they weren't going to do anything with the information, then maybe that helps to get you to it not being a breach. But the takeaway here is the facts are going to dictate, and the more you let the cat out of the bag, the more difficult it is to say there's been no breach. Hypothetical 5, this is a similar circumstance, but one we see a lot. A clinic sends a group email to patients who may be interested in weight management counseling. The person from the clinic who's sending the email forgets to blind copy recipients, and instead everyone who receives the information sees all other recipients' email addresses. Is this a HIPAA violation? Well, it's probably an impermissible use or disclosure because those people where the recipients didn't agree that their information would be disclosed to the other people who are recipients. Whether it's a breach, again, depends on the facts. It depends on the content of the email. What does the email say? Does it recognize these people are patients? Does it have health information? Does it talk about recent use of the clinic? Are the email addresses identifiable? That's another hurdle that you have to deal with. If email addresses are so unclear as to who it is, maybe you could argue that with respect to some recipients, it's not a breach. But again, those are the facts and circumstances you're going to be analyzing and determining whether you need to report it. And then I would also say, if you can recall the email without it being accessed, then you very well may be in a situation where you can argue it's not a breach. And then finally, our last hypothetical is a little bit of an interesting one, but I think one that is becoming more common. Let's say a fitness app developer, like a MyFitness, for example, or something similar, asks a primary care clinic for a patient list so that the app developer can then provide information and contact the patients directly who've asked the clinic, the patients who are on the list about. They want to contact the patients about the app. So the question is, may the clinic provide the list to the fitness app developer? Well, this is really interesting. Remember that when you're disclosing PHI as a covered entity, you need to decide if you're doing it for a permitted purpose. So is it for treatment? Is it for payment? Is it for healthcare operations? maybe you could argue that disclosing the patient list is for treatment purposes. I think that's a little bit of a difficult argument to make. Reasonable people could differ as to whether an app developer is in fact, a fitness app is in fact someone who's getting information for treatment purposes. So you're not on very solid ground about disclosing it for treatment purposes, in which case, if you don't have a permitted purpose, you would need consent or authorization of the patient. This hypothetical also gets into some questions about whether you can provide information for marketing communications. Now, if the fitness app developer had paid the clinic for the patient list in order to contact the patients, you would definitely be in a scenario where you are engaged in marketing. And marketing communications require the consent of the patient. So you need to be aware that if there's ever a third party looking for a patient list, you need to decide if it's something that, first of all, you need to figure out if there's money exchanged. If you're getting paid for a patient list, then you are likely involved in the sale or marketing and you need to get the patient's consent. Certainly you can send information, as the covered entity, you can send information to patients about your own products or services. But in this case, we have a third party sending information about a third party's products and services. So you're definitely in the land of needing to check and verify with your privacy officer about whether the patient list can be disclosed.